Welcome to MRCS and Beyond. This is the Viva Ready series, where we tackle high-yield OSCE topics in detail. If you haven't already, don't forget to follow and subscribe to keep up to date with new videos. And do check the link in the description for our complete MRCS podcast series and accompanying notes. Let's get into it.
So this is our roadmap for Part 1. 4 blocks. We'll start with the abdominal aorta itself, its course from T12 to L4. Then we'll go through the 3 midline visceral branches you absolutely must know: celiac trunk, SMA, and IMA. We'll cover aneurysms, the definitions, the types, and what makes them surgical emergencies. And we'll finish with the IVC, how it forms, where it goes, and the tributaries that trip people up in the Viva. Stick a finger in this slide as a contents page, and let's begin.
A quick breakdown of the 6 headline topics: the aorta and its branches by vertebral level, the anterior relations crossing it, that's a classic Viva question, aneurysms and the 4 types you need to recognize, the celiac trunk's 3 branches, SMA and IMA territories with the marginal artery, and the IVC with the mnemonic for its tributaries. 6 topics, all high yield. Let's go. The abdominal aorta begins as the thoracic aorta pierces the diaphragm at the aortic hiatus at vertebral level T12, and it ends by bifurcating into the 2 common iliac arteries at L4. Roughly 13 centimeters long in an adult. Now, the way to remember its branches in the Viva is to split them into 2 pairs of categories: paired versus unpaired, and parietal versus visceral. The 3 unpaired visceral branches sit in the midline: celiac, SMA, and IMA, and they supply the foregut, midgut, and hindgut respectively. The paired visceral branches come off the sides: middle suprarenal, renal, and gonadal. The paired parietal branches are the inferior phrenics and the lumbars, and the one unpaired parietal branch is the median sacral, coming off the back just above the bifurcation. Get that framework solid: paired versus unpaired, parietal versus visceral, and the rest is just memorizing the levels. This is the table you want burned into your retina. Top down. At T12, the inferior phrenic arteries, paired, parietal, and the celiac trunk, unpaired, visceral. At L1, the superior mesenteric artery, unpaired, visceral, and just below it, the middle suprarenal arteries, paired, visceral. L1 to L2, the renal arteries, paired, visceral. L2, the gonadal arteries, paired, visceral. These are the testicular arteries in men, ovarian in women, and they have a long descent. L1 to L4, the lumbar arteries, 4 paired parietal branches supplying the posterior wall. L3, the inferior mesenteric artery, unpaired, visceral, sitting about 3 to 4 centimeters above the bifurcation. And finally, at L4, the median sacral artery, unpaired, parietal, and that same level marks the bifurcation of the aorta itself. If an examiner asks, where does the SMA arise, you answer L1, just below the celiac, without hesitation. Anterior relations of the aorta, top to bottom. This is a favorite Viva question. Working downward, the celiac trunk and its branches, then the body of the pancreas, then the SMA as it emerges from behind the pancreas, then the left renal vein as it crosses the midline, then the splenic vein, then the 3rd part of the duodenum, that's D3, and finally the root of the mesentery itself. Now, the transpyloric plane of Addison. It's an imaginary horizontal plane lying halfway between the jugular notch and the upper border of the pubic symphysis, at vertebral level L1. What does it cross? 6 classic structures. The pylorus of the stomach, that's where the name comes from, the fundus of the gallbladder, the neck of the pancreas, D1, the hilum of the left kidney, and the tip of the 9th costal cartilage laterally. Clinically, this is where the SMA arises from the aorta and where the splenic vein and SMV meet behind the pancreatic neck to form the portal vein. So in one horizontal plane, you've named most of the upper abdominal landmarks. Powerful answer to have ready.
An aneurysm is a permanent dilatation of an artery, more than 1.5 times its normal diameter. For the infrarenal aorta, the working threshold is greater than 3 centimeters. There are 4 types to know. True aneurysm, the commonest, typically a saccular infrarenal AAA, and the underlying pathology is medial cystic necrosis, degeneration of the tunica media. False or pseudoaneurysm, almost always post-traumatic. The blood is contained by not all 3 arterial layers, but by surrounding perivascular tissue. So it's not a true aneurysm at all, it's a contained leak. Dissecting aneurysm, a separation of the arterial wall layers, classified by Stanford as type A, involving the ascending aorta, that is a surgical emergency, or type B, distal to the left subclavian, managed medically in the first instance. Mycotic, infective, classically with Salmonella or Staphylococcus, rare but high rupture risk because they expand quickly. Risk factors: smoking, hypertension, atherosclerosis, Marfan syndrome, syphilis, bicuspid aortic valve, and the catastrophic complication rupture at any level, particularly devastating with type A dissections that extend up to compromise the arch and cause stroke.
The celiac trunk arises at T12 from the anterior surface of the aorta, and it supplies the foregut. That's from the abdominal esophagus down to the ampulla of Vater in D2. 3 branches, easy mnemonic: left gastric, common hepatic, and splenic. Left gastric, the smallest branch, runs along the lesser curvature of the stomach. Critically, it gives off esophageal branches, and that is the site of esophageal varices in portal hypertension. So when you see hematemesis with cirrhosis, that's the anastomosis you're thinking about. Common hepatic divides into the proper hepatic, which itself gives the right and left hepatic arteries, and the gastroduodenal, which gives the right gastroepiploic and the superior pancreaticoduodenal arteries. Splenic artery, the largest and most tortuous, runs along the upper border of the pancreas, reaches the spleen via the splenorenal ligament, and gives off the short gastric arteries and the left gastroepiploic on the way. 1 trunk, 3 branches, foregut covered. Now let's tie branches to territory. These are the high-yield clinical pearls. Right gastric artery, a branch of the proper hepatic, supplies the lesser curvature, anastomosing with the left gastric. Cystic artery, typically arising from the right hepatic, found within Collat's triangle during a cholecystectomy. Gastroduodenal artery runs posterior to D1. Why does that matter? Because that's the artery you erode into with a posterior duodenal ulcer, and it bleeds catastrophically. Classic exam scenario. Right gastroepiploic, anastomosis along the greater curvature. Superior pancreaticoduodenal supplies the head of the pancreas, and it's part of the foregut midgut watershed, anastomosing with the inferior pancreaticoduodenal from the SMA. Short gastrics from the splenic supply the fundus of the stomach, and the left gastroepiploic, also from the splenic, supplies the greater curvature on its left side. So when an examiner points anywhere on the stomach and asks for the blood supply, you can build it up logically. Lesser curve,
from left and right gastric. Greater curve from the two gastroepiploics. Fundus from short gastrics. One coherent story.
The SMA arises at L1 just below the celiac trunk from the anterior aorta. It supplies the midgut from the major papillae in D2 through to the proximal two-thirds of the transverse colon. Anterior relations, the neck of the pancreas and the splenic vein. Posterior relations, the left renal vein, the uncinate process of the pancreas, and D3. This is the anatomical basis of SMA syndrome, compression of D3 between the SMA anteriorly and the aorta posteriorly. Rare but real, and a classic Viva curveball. The named branches, and you should be able to rattle these off. Inferior pancreatico-duodenal, the first branch, supplies the lower head and the uncinate. Jejunal and ileal arcades, and remember the difference. Jejunum has fewer arcades and longer vasa recta. Ileum has many short arcades. Middle colic to the transverse colon. Right colic to the ascending colon. Ileocolic, the final major branch, supplying the cecum, terminal ileum, and the appendix via the appendicular artery. Venous return parallels the artery. The SMV joins the splenic vein behind the neck of the pancreas to form the portal vein. So if you wanted, the SMA is your one-stop tour of the entire midgut.
The IMA arises from the anterior aorta at L3, about 3 to 4 centimeters above the bifurcation. It supplies the hindgut from the distal one-third of the transverse colon down to the upper rectum. 3 named branches: left colic, distal transverse and descending colon, sigmoid branches, sigmoid colon, and superior rectal, the upper two-thirds of the rectum. The IMV ascends and drains into the splenic vein, though occasionally directly into the SMV or at the splenomesenteric confluence. Now the key clinical concept, the marginal artery of Drummond. This runs along the mesenteric border of the colon, providing collateral communication between SMA and IMA territories. So in theory, the colon has a continuous arcade running its full length. But, and this is where the exam comes in, the splenic flexure sits at the watershed between SMA and IMA, and it's the most vulnerable colonic segment to ischemia, particularly in low-flow states or after AAA repair. So if you're ever asked about ischemic colitis localization, that's your answer.
The IVC forms at L5, where the two common iliac veins unite. It ascends to the right of the aorta, pierces the central tendon of the diaphragm at T8, and empties into the right atrium. Tributaries, and the classic mnemonic, I like to rise so high. I, iliac veins, the common iliac veins that form it. L, lumbar veins, draining the posterior abdominal wall. T, testicular or gonadal veins, and here's the asymmetry, the right gonadal drains directly into the IVC, the left gonadal drains into the left renal vein first. R, renal veins. The right is short, the left is longer because it has to cross the aorta, passing between the aorta posteriorly and the SMA anteriorly. We'll meet that geometry again. It's the nutcracker syndrome anatomy. S, suprarenal veins, again asymmetric, right into the IVC directly, left into the left renal vein. H, hepatic veins, draining at T8 just before piercing the diaphragm. 1 mnemonic, 6 tributaries, exam ready.
The 6 points to walk out of this video with: 1. Abdominal aorta runs from T12 to L4, about 13 centimeters long. 2. 3 unpaired visceral branches, coeliac at T12, SMA at L1, IMA at L3. 3. The watershed between SMA and IMA is the splenic flexure, connected by the marginal artery of Drummond. 4. The transpyloric plane at L1, pylorus, gallbladder fundus, neck of pancreas, D1, hilum of left kidney. 5. AAA equals greater than 3 centimeters of the infrarenal aorta. Commonest is saccular infrarenal, smoking, hypertension, Marfan as risk factors. 6. IVC runs from L5 to T8. Left gonadal drains into the left renal vein, right gonadal drains directly into the IVC. If you can deliver those 6 bullet points in the Viva, you've crushed the vascular anatomy.
So, that's part 1 done. In part 2, we move into the solid and hollow viscera: liver, gallbladder, pancreas, spleen, esophagus, stomach, and duodenum. We'll cover Cantley's line, Quino's segments, Calott's triangle, the biliary tree, the islets of Langerhans, the rule of odd numbers for the spleen, and the 4 parts of the duodenum with the ampulla of Vater. If this has been useful, hit the subscribe button so you don't miss it. Drop a comment if there's a specific Viva topic you'd like me to drill in detail. And check the video description for the link to buy the full MRCS OSCE Preparation Podcast when you're ready to go deeper. Thank you for watching, and I'll see you in part 2.